Okay, I think I may have misspoken here, and so I want to make sure that I say this correctly. If I misspoke, I apologize. But blanchable hyperemia is when the reddened skin area turns a lighter color with fingertip application. So if you press onto your skin with your finger, it will usually turn white or lighter color when you do that. If you have non-blanchable hyperemia, that's when the redness stays. It doesn't turn white when you press onto it. So that tells us that there's some redness under that skin. Undermining is another term that we need to know, and that is when skin separation from the underlying granulation tissue is at the wound edges, and when hoping to look at a picture of that in class so you can see what that looks like. And then tunneling is a larger pocket of necrotic tissue beneath the wound opening, which means you might not be able to see that tunneling and how deep it goes because it's smaller than the actual wound. Or the wound opening is smaller than the tunneling. Could be either. So risk factors for pressure ulcer formation. Throughout this presentation, we'll be looking at different people, case study to help us learn more about skin integrity and wound care. And this is an example of a Braden scale case study. Using the Braden scale is important. It is also part of your clinical paperwork and also used in long-term care. And it's a tool to determine risk factors for pressure injury. So if we have a 76-year-old 7-day post-op hip replacement patient who has a history of smoking and diabetes, he has some foul-smelling drainage from his incision, he has an elevated temperature, and he is diaphoretic, which means he's sweaty. His skin is wet. He is reluctant to reposition due to pain, and he prefers to lay supine. He drags himself to the side of the bed for a wheelchair transfer. He is continent of urine and stool. He is not eating well. He does complain of sacral pain, and he has some redness without blanching. So what risk factors does this patient have for pressure ulcer, pressure injury development? His age, he's older, he has some immobility due to his post-op pain status. These two will combined definitely decrease blood flow to all the tissues. He does have impaired oxygenation because of his history of smoking. He has poor nutrition. He has altered circulation, probably due to surgery. And question, because he has diabetes, does he have a possibility of atherosclerosis? And definitely diabetes increases his risk for infection and decreases wound healing. So if we look at the Braden scale, you can pull that up on your Moodle. He has sensory perception, which seems fine. He does have moisture on his skin because he is diaphoretic. So that score is a 1. His activity is a 2. He has had a hip replacement. He can't bear weight. He uses a walker, requires assistance. Mobility is a 2. He is reluctant to move, although he can do so independently. His nutrition score is a 2, and friction and shear score is 1. So he has a very high risk for pressure injury due to his score of 12. If we talk about origins of pressure ulcers, people are at risk. They often develop quickly when people are at risk because the patient is ill, or the other risk factors that we just talked about are great examples. Statistics for pressure ulcers are not great. A lot of people are reluctant to report them, especially when they're stage 1. So people estimate anywhere from, I've seen 15 to 20% of patients develop pressure injuries. But what happens when that pressure against the skin surface is exerted and exceeds 12 to 32 milligrams of mercury, the vessel occludes, which causes ischemia to the tissues, and the tissues don't have enough oxygen to do what they need to do. The areas of greatest risk are bony prominences and the surface connecting with the surface of a bed or a chair. And duration of pressure, so the longer pressure is applied, the more likely is that tissue loss will occur. So we see that with high pressure over a short time or low pressure over a longer time. Either one of those cause skin breakdown. As well as tissue tolerance. So tissue tolerance can alter the ability of the skin and supporting tissue to respond to pressure. So shearing, friction, moisture, nutrition, infection, age, all those risk factors. Integrity of skin and supporting structures influence ability of the skin to redistribute the pressure. And I'm hoping that you think about your anatomy and physiology class, the skin, how the skin works and what helps support the skin. Again, when those vessels are occluding, all that tissue cannot work the way that it should. Remember to look in your textbook, box 38.2, that talks about factors affecting wound healing. So let's talk about wound healing. Wounds can heal by primary intention, secondary intention, or tertiary intention. Primary intention is for usually a wound with little or no tissue loss, such as a clean surgical wound. The skin edges approximate or close together, and risk for infection is minimal. So a lot of times you might see that they're stitched or stapled or glued together. Secondary intention is wound involving loss of tissue, such as a severe laceration or a chronic wound, such as pressure injury. The skin edges cannot come together because of the extensive tissue loss, and healing occurs gradually. A layer of granulation tissue, that's the new healing tissue that you'll see in the wound bed. That layer of granulation tissue is red and moist. It consists of blood vessels, connective tissue. It will cover the base of the wound. And eventually the wound contracts, which brings the wound edges together. The wound closes with scar formation. Then we have tertiary intention, which sometimes the surgical wound might be initially closed in the deep tissue layers. However, the subcutaneous fat and skin layers are left open. This is called tertiary intention or delayed primary closure. The wound then heals with that layer of granulation tissue at the edges and the base, and the initial wound healing, the wound will eventually, edges will come together, sometimes again with sutures or adhesive closures like glue. So going back to the nursing process, looking at diagnoses for skin issues. One thing that we see a lot of times with skin issues has to do with their ability to heal. And so we'll see risk for infection, impaired bed mobility, impaired physical mobility, imbalanced nutrition, less than body requirements, acute pain, chronic pain, impaired skin integrity. So that's one we'll see often. Risk for impaired skin integrity, ineffective peripheral tissue perfusion. And some of the things that we look for when we're getting ready to make our nursing diagnosis are descriptions of wounds. Sometimes we'll see hemorrhaging and internal hemorrhaging, internal bleeding. We might see some shock. We might see swelling of the affected body part. Hematoma, which is a localized collection of blood under the tissue. A bruise, and it's more than a bruise. A hematoma is bigger than a bruise. It can look like red or blue swelling or even feel like a mass under the skin. External hemorrhaging is obvious because we see blood. Sometimes surgical drains are used to collect blood and pull that extra fluid out of the tissues. The infection development timeline. So bacterial wound infection prevents healing by increasing tissue damage and altering the wound healing process. The chances of wound infection are greater when the wound contains dead or necrotic tissue, when foreign bodies are in or near the wound, and when blood supply and local tissue defenses are lower than normal. A contaminated or traumatic wound infection can develop within 2 to 3 days. A surgical wound infection within 4 to 5 days. Drainage is often yellow, green, brown. It can be odorous depending on the causative organism. Dehiscence is a partial or total separation of layers of skin and tissue above the fascia in a wound that is not healing properly. Obese patients have a higher risk for dehiscence because of that constant strain on their wounds with the extra tissue and poor vascularity of adipose tissue. It occurs most often in abdominal surgical wounds after a sudden strain, such as coughing, vomiting, or sitting up in bed. Patients often report feeling as though something has given way. And when serosanguinous drainage increases from a wound, we need to be alert for dehiscence. Evisceration occurs when wound layers separate below the fascial layer and visceral organs protrude through the wound opening. Evisceration is a medical emergency that requires the placement of sterile towels soaked in sterile saline over the extruding tissues to reduce the chances of bacterial invasion and drying before surgical repair occurs. So if we go back to Mr. Ahmed, he cannot tolerate positions that might relieve or reduce pressure to his skin. So as a nurse, you need to think what to do about that. Really at this point, we need to find what type of surface would be appropriate to decrease pressure on Mr. Ahmed's skin. That may include a special bed or a special mattress for him that will relieve pressure. And we know that he has this wound that's about 1 by 2 inches. It's full thickness over the sacral area with a red moist base. He has reddened skin around the wound. So what else can we assess? We inspect and palpate the wound, the temperature. Is there any drainage? What pain the patient has in that area? All be great things to document. Mr. Ahmed is eating fewer than 1,600 calories. So what is the first thing you do? Remember, the first thing we do in nursing is we go by the nursing process. So we want to assess, what are we going to do for Mr. Ahmed? We're going to do a calorie count for him and see how much food he actually is eating. So if we choose a diagnosis for Mr. Ahmed, the really appropriate diagnosis for him would be impaired skin integrity related to pressure over bony prominence in the sacral region. And the goal for him for that nursing diagnosis, pressure will be reduced to the sacral area and the wound will show movement toward healing within 1 week. So if we identify our outcomes that are all going to go toward that goal, I want you to think about what outcomes would we measure. Remember, for Mr. Ahmed, it's important to set achievable goals for him. And so some examples, we could say wound will decrease in diameter within 3 days. No evidence of further wound formation will be noted in 7 days. So those would be great, reasonable outcomes for Mr. Ahmed. One thing we need to do is we need to make sure that we are performing frequent skin assessment. So if we have a patient in the hospital, that skin assessment is done daily, if not every shift, paying special attention to bony prominences. We do not massage reddened areas because those reddened areas that are non-blanchable are already injured, and massaging creates further injuries. So we need to position the patient to reduce pressure and shear on the skin. That might mean turning every 2 hours. If they're in bed, or more, if they have an ulcer, it might need to be done every hour. There are so many different types and brands of dressing. I know you got a chance to look at some of them in your CSC lab, but I'm going to talk about a few of them here. There are dry dressings and moist dressings. Most are pretty easy to apply. It is best to keep a somewhat moist environment that produces normal epidermal cell growth and also absorbs drainage to prevent bacterial growth, because we want to prevent infection. Sometimes, if a wound has minimal drainage, it will create a natural formation, a seal that eliminates the need for a dressing. So if we're talking about we want to have a wound that has depth to it, we want to eliminate dead space. And so that is why we pack a wound. And sometimes we need one that absorbs drainage. And so to allow the wound to heal by secondary intention. And there's Mepilex, which is a foam dressing. That's one you'll see often in long-term care. We have alginates like Aquacel or Convatec type of dressing. So those are examples of dressings that absorb drainage from wounds. We also want to make sure that we immobilize the dressing, that it's taped on, it's not going to fall off. When you're planning a dressing change, you want to consider the pain of the patient. And if you can give if the patient has pain, you can give some type of analgesic 30 to 60 minutes prior to a dressing change. And you may need to stop and take a time out during the dressing change for pain. You may schedule that dressing change for when the patient is feeling best during the day. You may have to soak dry dressings before removed unless a wet to dry dressing is ordered. Remember that wet to dry dressing, we want it to dry out, and when we pull it out, to pull any slough or dead tissue with it. If it's really hard to get off, I'm talking really hard, then you maybe can moisten it just a little bit to pull off that wet to dry dressing. But in general, you want it to be dry when you pull it out. You want to avoid aggressive packing of a wound because it can cause pain, but it can also cause more pressure into the injury if it's packed too full. You definitely want to position the patient to provide comfort. And you want to consider using low adhesive dressing if possible, just so that when you pull it off, it's not causing so much discomfort for the patient. When you're cleaning a wound, you always want to clean from the least contaminated area to the most contaminated. Use very light friction. And if you're irrigating, you would also have the same principle, irrigating from the least contaminated area to the most. So you're not pushing contamination into the clean areas. Usually we use normal saline when cleaning a wound. Sometimes an antiseptic. You have to be careful with antiseptics because we don't want them to inhibit healing. For wound irrigation, this is a way to cleanse and get all out any extra drainage or debris, necrotic tissue. So they're useful for cleaning those open, deep wounds or inaccessible body parts due to tunneling. The temperature should be at body temperature if possible. You're going to use normal saline. A safe pressure for irrigation is 4 to 15 psi because you don't want to create any more trauma in a pressure injury or any other type of injury. Make sure the syringe tip is over but not touching the wound. Do not use iodine, peroxide, or anything else to irrigate a clean granular wound because those solutions are toxic to the cells that we need for wound healing. For taking care of sutures, we might just need to gently cleanse them with normal saline. And then different facilities have different policy for suture removals. And so if you are going to remove sutures, you need to make sure that you get an order from the healthcare provider. I mentioned drains earlier, that sometimes they are used to prevent excess exudate or drainage. And there is a video here that talks about JP drains. There are many different types of drains, which you will see throughout your nursing career. And very often you'll be teaching a patient how to empty their own drain. And so it's really important that you familiarize yourself how to use that drain before you're educating the patient. And so each facility has the brand and type that they use for different types of drain, but the rationale behind that is to pull out all that extra fluid. It decreases swelling, gives bacteria less space to grow in, and also can decrease pain because you're decreasing the swelling. When it comes to bandages, you should know that we have principles for applying them, that you always want to inspect the surrounding skin for abrasions, edema, discoloration, exposed wound edges. Inspect the condition of underlying dressings of changed and soiled, and change if the dressing is soiled. Cover exposed wounds or open abrasions with a sterile dressing. Assess the skin of the underlying body parts that are distal to the dressing for signs of circulatory impairment, such as pallor, cyanosis, coolness, absent or diminished pulses, swelling, numbness, tingling, to make sure that the dressing is not cutting off circulation. And abdominal binders are used usually to support large incisions that are vulnerable to stress when a patient moves or coughs, and they are usually secured with Velcro. Heat and cold therapy are used frequently in healthcare. And before applying heat or cold, first you want to assess the area so you are able to evaluate the therapy-related changes. You want to identify conditions that contraindicate heat or cold therapy. So what would that mean? So if you have a pressure injury, you're not going to want to put hot or cold onto it. That would be a good example. We are responsible for safe administration of heat and cold applications in the clinical setting. So I know a lot of patients will say, well, I just put my heating pad right up against my skin at home. This is what I do at home. But we are responsible for the safety of the patient's skin integrity. And so we may need to do some education there. So some systemic responses. Heat loss mechanisms can cause sweating or vasodilation. So heat conservation, vasoconstriction, and heat production would cause a shivering. Local responses to heat and cold occur through the stimulation of temperature-sensitive nerve endings within the skin. The body is very adaptive, right? And can take a lot of abuse before injury occurs, but we still need to watch those temperature extremes. And sometimes our patients don't feel those. And again, because we're responsible for what's happening with the heat and cold therapy, we need to use short times for heat and cold therapy. So they can't sleep with their heating pad. They can't sleep with their ice pack. So if we look at what happens from heat, we see vasodilation, decreased blood viscosity, decreased muscle tension, increased tissue metabolism, and increased capillary permeability. And the effects of cold would be vasoconstriction, local anesthesia, decreased cell metabolism, increased blood viscosity, decrease muscle tension. So all those responses depend on the duration of application. So shorter application time is better. The body part. So if you're talking about the foot or the palm of the hands, they don't have as much sensitivity, nerve endings, feeling. If you're at the neck or the inner wrist or forearm, very more sensitive to temperature therapy. Damage to the body surface. So exposed skin layers are going to be more sensitive. Prior skin temperature. So if the patient has a fever, they're going to feel that cold therapy more so if they were a normal temperature. The body surface area. So if you're adding a large cold pack, large heat therapy, it's going to make more of a difference than if it's small. The age and physical condition. The very young and very old are more sensitive. And the patient's physical condition can reduce the perception of sensory stimuli. So lots of assessing if you're using heat or cold therapy to assess that skin for safety. When we're evaluating, we're comparing the patient response to the desired goals and outcome, just like for any evaluation. And if we evaluate and are not meeting our goals and outcomes, then we may need to get additional support, initiate referrals, make some changes. And we also want to make sure that we know what our patient expectations are when it comes to wound healing. There are some people who will have chronic wounds that last for years and years and years, and they may never completely heal up. And so we need to make sure our patient expectations are realistic, and maybe just see, does the patient need or want family support or other types of support for such long-term chronic ulcers. So that is the podcast for skin integrity and wound care.